Hearing as a subcommittee, I have with me the member for Kooyong.
Good afternoon. Monique Ryan, I'm an independent member for Kooyong in Melbourne.
Yep. There's just some formalities to go through. I declare open this public hearing being held in Canberra of the House Standing Committee on Health, Aged Care and Sport for the inquiry into health impacts of alcohol and other drugs in Australia. We're appearing as a subcommittee. I remind all present that as Chair I will ensure that proceedings are conducted in an orderly, respectful and courteous way. In accordance with the committee's resolution of the 4th of August 2022, this hearing will be broadcast on the Parliament's website, and the proof and official transcripts of the proceedings will be published on the Parliament's website. I now welcome witnesses to give evidence today. For the Hansard record, would you please state your name and the capacity in which you appear before the committee? This hearing is a legal proceeding of the Parliament. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to make a short opening statement before we proceed to discussion. So welcome.
Thank you. Can you hear us okay?
Yes.
Yes. Okay. Nice to meet you all. I'm Professor Leanne Hydes. I'm Deputy Director of the National Centre for Youth Substance Use Research, and I'll let Daniel introduce himself.
Thank you. I'm Dr. Daniel Stepanovic. I'm a Senior Research Fellow at the National Centre for Youth Substance Use Research.
Okay. Thank you for the opportunity to appear today. The Australian National Centre for Youth Substance Use Research, or NISA, at the University of Queensland is committed to promoting the health and wellbeing of young people by increasing Australia's capacity to effectively respond to the harms associated with alcohol and other drug use. Today we'll just be presenting a brief summary of our written submission. So the Australian National Drug Strategy acknowledges the significant risks of drug use and the need for comprehensive support to reduce harm. However, responsibility for funding and implementation is largely at the state and local levels. This results in inconsistent approaches in alcohol and other drug treatment and policy across Australia. So this is why we strongly advocated for the re-establishment of a national AOD governance structure to oversee the implementation of the NDS in our written submission. Secondly, there's also a critical need to address demand for alcohol and other drug treatment in Australia. Current services meet only 56% of demand, with long wait lists and limited access in regional and remote areas, particularly for priority populations like youth. We recommend increasing funding for drug and alcohol treatment programs to ensure evidence-based care is available to all Australians. Although the National Quality Framework for Drug and Alcohol Treatment Services was created in 2018, it has not been properly implemented due to lack of funding and governance structure. Additionally, there is no national system for tracking the quality, outcomes or effectiveness of drug and alcohol treatment. The National Minimum Data Set, or NMDS, fails to collect data on treatment types or client outcomes, leaving gaps in understanding of treatment effectiveness. To improve this, we recommend expanding the National Minimum Data Set to include data on treatment types that are used during withdrawal management, counselling, rehabilitation and pharmacotherapy. We also advocate for enhanced clinical training to ensure staff have the skills and abilities to deliver evidence-based treatment. Finally, we are also strongly advocating for the routine collection of person-reported outcome measures, or PROMs, directly from clients to monitor treatment progress and improve client outcomes. In 2019, we developed Quick Fix, a person-reported outcome measure system funded by the Commonwealth Parliament of Health, designed specifically for drug and alcohol services. Quick Fix collects client outcome measures and provides personalised feedback. It has been used by Lives Well Services since 2020, collecting data from over 45,000 clients to date. Quick Fix was developed with maximum flexibility to ensure it can be adapted for use across a variety of drug and alcohol services and systems. With this adaptability, Quick Fix offers a national, scalable solution to improve the quality of drug and alcohol treatment services across Australia through better monitoring and the reporting of client outcomes. Daniel's now going to speak a little bit more about some of the priority populations we're interested in working with.
Thank you, Leanne. So I will briefly discuss two priority populations that currently lack equitable access to services before highlighting avenues beyond health that could be bolstered. Most young people in Australia will use alcohol and other drugs. Currently, more than 1 in 10 young people vape. The majority will drink alcohol, and just under half will do so at dangerous levels. Young people are more likely than any other age group to use illicit drugs in Australia. Despite this, the current health system fails to engage or adequately treat young people. Only a small fraction will seek treatment, and when they receive treatment, it is on average 18 years after the onset of a problem. Young people present with poorer mental health than other age groups when seeking treatment, highlighting the complex needs of this population. It is therefore crucial that there is dedicated research funding to understand how to prevent alcohol and other drug use problems in young people and how best to engage them in treatment. Treatment services also need to be sufficiently funded and integrated to address the complex needs of young people. Individuals from culturally and linguistically diverse or cold backgrounds are also underrepresented in AOD research, resulting in treatment services that lack culturally appropriate interventions and support systems, affecting the quality of care that they receive. There is an urgent need for culturally responsive AOD service initiatives that specifically address the needs and experiences of these communities. Further research funding is required to understand how best to prevent AOD use in cold populations and provide adequate treatment. I will lastly, quickly, in the interest of time, touch on 2 programs and services that could be bolstered to improve the outcomes of young people and the wider Australian community. First of these is drug checking services, otherwise known as pill testing within the ACT. These services give individuals the opportunity to have drugs tested to understand if the drug that they are using is what they expect it to be or if it has been adulterated. These services are currently limited to a small number of sites in some capital cities despite their strong harm reduction effect. The expansion of these services to better cover metro, regional and rural areas would provide important harm reduction to the wider Australian community. And lastly, police drug diversion programs divert people who use drugs away from the criminal justice system and are supported by the majority of the Australian population. These programs have been found to be effective in preventing criminal reoffending, improving health outcomes, and reducing social costs. We therefore advocate for further public health and implementation research to inform how best to run police diversion programs to meet the local needs of communities. In the interest of time, I will leave it there. There are a number of other recommendations within our written report. Thank you.
Thanks very much. I should note we've been joined by Jodie Balia from Victoria, but we might start with Monique with questions.
Oh, thank you. So, can I ask, Monique Ryan, from Kooyong, how are you funded and whether you have an ongoing source of dedicated funding?
Yeah, so NISA is one of the 5 funded addiction research centres by the Commonwealth Department of Health and Ageing Alcohol and Drug Branch. So we've had funding from them since 2017. There was a tender that went out that we applied for and we became one of the additional centres that were funded at that time. So we've got had several contracts today. The first one was, I think, 3 years, and then there's been a few additional contracts since then. Okay, so is ongoing funding a concern for you or something that you have to deal with? Yes, it's always a concern. The funding that we receive we're very grateful for it. It helps us fund central staff, but we basically have to still apply for funding from other research fellowships and grants to fund most of the research that we do. Right. So, and just in terms of, you've talked about the fact that we need sort of a national governance structure to oversee drug policy in this country, and I think probably members of this committee would tend to agree with you. How would you see that working? Where should it be placed, and is it within the Department of Health, or how would it work exactly in your perfect world, do you think? I think in a perfect world it would consist of leaders from the Commonwealth and state and local agencies all working together to look at drug and alcohol policy and treatment across every state and territory in Australia. Where it would be located, I don't think there could be a location. I think it would need to be a meeting from parties from all over Australia. Okay, yep, sure. And
I guess I'm interested, and I'm sure you're right. There's no doubt that one of the challenges is provision of services to people from culturally and linguistically diverse backgrounds, and then of course there's always the similar challenges with rural and regional settings and First Nations communities as well. How would you see all of that service provision working again in a sort of a best practice situation?
It's a great question. I guess, we'll never be able to have services available to every person in Australia. It's just not possible because of our geography. And a lot of investment has gone into digital health solutions. And I guess some of the issues with that is that people don't tend to engage with that technology very much, particularly if they're doing it by themselves and it's all self-completed. So we've done some work using telehealth interventions with young people where we had great success at engaging them in brief interventions, not without chasing them a lot, however. And we had a web app that supported the delivery of that telehealth intervention for clinicians to guide them through treatment. And some of our recent initiatives have built upon that to look at applications such as artificial intelligence to try and bolster that, to help clients and young people work their way through interventions. Because even with telehealth, there will never be a workforce with the capacity required to deliver treatment for everyone. Right. So we're looking at all sorts of solutions.
Right. And is that AI via input into telehealth or on other platforms in other settings?
So we just submitted a grant actually to the latest Medical Research Future Fund using generative AI to engage and guide young people through a brief intervention through a web app, which is which is like a mobile app that works on the internet as well. So that's how we sort of see it working. It all needs to be co-designed with young people. So we're not sure what platform it will be on yet. It could be, they'll be looking at an app. It could be all by telehealth. It could be by something we don't even know exists yet.
Okay, last question, Chair, if I may. Are some of these young people to whom we're providing this services and, this support, would some of them be aged 16 or less?
Yes.
So we wouldn't want to be necessarily restricting those young people's access to this sort of content online?
Yeah, possibly. I guess it depends on how it's delivered. So if it was coming through social media, for instance, that could be a problem if the law is going to change about access to social media for under 16-year-olds.
Yeah.
I don't think it would impact on digital health interventions being delivered to young people through websites and mobile apps.
Yeah,
but probably definitely social media, so that could be a problem.
Okay, yep. Thank you very much. That's great.
Okay, thanks, Monique. Member for Dunkley.
Thank you. Apologies for being late. I was trying to slap downstairs, another important health issue. You talked about police and engaging police. Can I just understand a little bit more about your thinking on that? Did I hear that when in your presentation? I think I did. No?
Sure.
So we're talking about police drug diversion programs. So there was a new program that started in Queensland last year where the police were now diverting drugs. It was used to be drug diversion only for cannabis, but now it's for all drugs, the small quantities only, of course, where people are given a warning for one offence, and then if they're found in possession of illegal drugs again, they're offered two chances to go into a drug diversion health solution rather than going to the court system. And so that program's been up and running in Queensland for just over a year. And we're actually engaged in an evaluation of that program as part of our university. So that's the involvement of the police. So the police are leading that program. They created it.
It has had general support from the police because they, prior to the diversion program, they would make contact with about 20,000 individuals who possessed small quantities of drugs, who are now diverted out of the criminal system into diversion towards health and education. We also know from data collected by the Australian Institute of Health and Welfare that the majority of Australians do support a non-punitive approach to drug use.
Couple of questions. So, from the data that you've collected from this program to date, are you aware of a predominant age group?
Are you talking about the drug diversion?
Yeah.
Not at this point. Unfortunately, it's very early days in the evaluation. Can't answer that, sorry.
When will you have an evaluation report at some point? Do you know if the police are leading that or?
Depends on what happens with the program in Queensland. We're understanding that there'll be a 12-month report. I'm not sure, sorry.
Okay, no worries. Thank you.
Member for Hughes.
Thank you, Chair. Thank you, professors, for being here. I really thank you for your submission as well. It's very informative. I just want to start with, in your executive summary, you talk about investment in drug checking. We still got them?
Yeah.
I'm talking about drug checking and investment in drug checking. There's been a lot of commentary. This always is exciting each year when we have drug checking at some of the big festivals in New South Wales. Do you have any statistics or any information on the success or otherwise of drug checking or drug testing, and particularly around any statistics around any link between the drug testing and a lowering of deaths from some of the so-called party drugs or recreational drugs in teenagers particularly?
So the drug checking service in Queensland is quite new. It's only been operating for a few months now. They've only attended 2 festivals. The second fixed site has just opened and operates for a few hours per week. The data that has come out of this is quite preliminary, but it does show that when someone has their drugs tested and is informed that that drug, usually a party drug, does not contain what they think it does, they usually discard it and choose not to use it. So there is strong evidence that there is a harm reduction potential, but we will need to monitor it for a longer time to really understand how far that goes.
Okay, thank you very much for that. Also, are you able just to talk through a little bit about the wastewater epidemiology and where you've seen that you're calling for more investment in it? Have you seen, where can you point to examples where you've seen that this has been successful?
So there are, I think, to my mind, 2 examples where wastewater has been quite successful in terms of substance use monitoring. So just as background, the way that it works is that small samples of waste from the normal sewer system are collected, and these can be tested for various chemical substances. It's quite easy to monitor the use of a large number of drugs by measuring just how much is present in wastewater over time. One area in which it is quite useful is detecting new drugs emerging. So if there are, for example, rises in fentanyl, these would show up in wastewater. The other is being able to monitor quick changes in substances. So we know that we missed some of the quick changes in e-cigarette or vaping uptake. And part of this is that the way in which we monitor drug use relies on national surveys. These occur every 3 years, which is quite a slow time. They are very useful in allowing us to know how much of the population use a particular substance, understanding why and how they use them and how they obtain them. But every 3 years is a bit of a slow time when it comes to quick changes in the drug use landscape. The other source of data that we rely on is tax data and sales. These are useful for legal substances such as cigarettes and alcohol, but they will miss new products and illicit products. So as cigarette use or tobacco use has switched to illegal cigarettes, nicotine pouches and vaping, these are missed in tax data. So while we saw continued decreases in the smoking rate in Australia, what wastewater indicated is that there was an increased use of nicotine. So our traditional data sources were missing vaping, chop and illicit tobacco, and nicotine pouches, but wastewater picked this up.
Right. Thank you. That's very helpful. My last question, Chair. I'm from New South Wales. I'm from southern and southwest Sydney. We've had the drug court established in New South Wales since I think around 1999, 2000. And I think that it's. I don't know if have you had any experience with, or are you able to speak about the drug court? I've just got a couple of questions about its model, but it may be that you say to me that's out of our area of expertise.
Yeah, it probably is. Because it's all changed now in Queensland, and the drug court in Queensland was certainly only for cannabis, so it's probably quite different to the one in New South Wales.
Oh, okay, then could I just ask you a couple of questions around the drug court in Queensland then?
Yeah.
So could you just explain, so it's only for cannabis?
Well, originally it was. I mean, I'm not even sure if it's operating anymore, so I probably can't really talk to it because it's all been changed with the new drug diversion laws coming in. So I think it's all probably quite different now. So.
Okay, thank you. I'll leave it there.
Yeah.
Thank you. I've just got a few other questions. And first of all, it's around trends. Are you noticing any trends? And I'll preface that by saying there's a lot of talk about perhaps young people drinking less alcohol. There's talk about new drugs coming to the market, the synthetic opioids, etc. Are you noticing any trends happening in Queensland?
So we have noticed nationally and within the individual states that, as you said, with young people, there is less alcohol and other drug use. So this seems to reflect a global shift away from drug use. What we do additionally see, though, is just demographic shifts in harmful use. So, for example, what we've seen declines in the number of young males who drink at dangerous levels. We've seen an increase in the number of young females who drink at dangerous levels.
Right. Yeah, and we've done a fair bit of work with the universities here in Queensland, and we certainly see the high rates of risky drinking continuing to occur in those settings. We know nationally that university students, particularly those that are living in residential colleges, tend to drink more than other young people their age that are not in university. So I think it's quite context dependent, like Daniel was saying, and I think we're certainly seeing that trend towards young women drinking at risky levels, sometimes more than young men. So that gap between risky drinking between young men and young women seems to have disappeared.
Closing, yeah. Okay. And what about other drug use?
Yeah, I mean, at the university level, we're not seeing much of it. But through the drug checking reports that are coming out through the service, we're certainly seeing quite a bit of illicit drug use. But a lot of young people don't seem to be going through those services yet. I think the festival data will be quite different, and that will tell us a little bit more about what young people are using. But we're not involved in that closely enough to comment on what they're finding. Right.
Okay. And we've sort of latched on to wastewater testing for a whole range of things. Doing a national wastewater screen that would look across the country to screen for what the trends are?
I believe it would be useful. It would provide, as Leanne highlighted in her section, sense of national governance, priority for a specific testing, so not just substance use, but as you highlighted, it was very useful during COVID to be able to detect potential presence of the virus within communities. At the moment, there are wastewater programs within the capital cities and some regional centres, but what is tested and how frequently varies between these. So a national structure would be useful for that.
Yeah, and
in a perfect world, we'd have wastewater checking data being triangulated with population level data to really try and understand, as well as data from emergency departments, for example, an ambulance, helping us see what's actually happening in real time, rather than these huge lags we have with the population level data and the gaps we have in the wastewater collection nationally.
yeah, there's been lots of calls for increased places in residential rehabilitation organisations, but we need to look at more innovative ways of offering rehabilitation. I'm talking, online programs and non-residential programs.
Yeah, look, I think a mixed approach is always going to be needed. I think residential treatment is often seen as first-line treatment, but it really shouldn't be. I think the public seems to think that is what drug and alcohol treatment is. I think we could probably educate the public that you do have other options. You could look at online resources. You could do a brief intervention with the drug and alcohol service, and then you could do a day program where people go in and receive the equivalent of residential treatment programs, but they stay in the community and then they're not cut off from their social supports, etc. There's pros and cons to every one of those. Residential treatment tends to be required when someone's got quite severe and complex substance use issues and kind of mental health and physical health and pain issues. And they often receive it when they've run out of other options. So they're homeless or about to be homeless, they don't have an income, it's sort of seen as that last resort. And it really shouldn't be. It's a valid treatment option, but I think it's got an important role, but there are a lot of other options that people could try first. Great.
All right. Thank you very much.
Ideally, we'd stop them getting to that point where they needed to go into residential treatment at all. We treat them way before that.
Yeah. Okay. Any further questions?
Not from me, thanks, Chair.
Good. All right. Well, we don't have any further questions, and thank you very much for appearing today. If you've been asked to provide any additional information, please forward it to the Secretariat by Thursday the 5th of December 2024. You'll be sent a transcript of your evidence. We'll have an opportunity to request corrections to any transcription errors, and I'd like to thank you once again for giving us your valuable time to talk to us today. So thank you very much.
Thank you.
Thanks.
Thank you.
Thank you.
Bye.